Hi everyone, my name is Cynthia Baltazar. I'm the program director of Mozambique Field Epidemiology and Laboratory Training Program. I work at the National Institute of Health in Mozambique, and I'm very delighted to have a very special person here, Dr. Gupte from India, and we are going to talk about the 9 lessons from eradication of smallpox. So Dr. Gupte, welcome. I'm so glad to have you. And the reasons that the main reason why you are here is because you were the one who was there. So I'd like you to introduce yourself, and I'll start my questions with my questions. Thank you.
Thank you. I'm Mohan Gupte. I started my medical education from Pune in BJ Medical College, where I started doing my job also as a lecturer. And that's the time when I started talking about smallpox, learning about smallpox. I established my own laboratory along with the field work. And that's how I began the entire work. I used to look after several epidemics, focusing also on smallpox. And there are several such epidemics. We can talk about some of those things as we proceed. From the BJ Medical College, Pune, where I was a reader, when I became professor also, I shifted to leprosy. And I spent almost 30 years of service, actual service in leprosy, continued working in leprosy for the next 10, 12 years. So total experience for leprosy is something like 40, 45 years. And I have been the professor, as I mentioned to you, of preventive and social medicine. I joined Indian Council of Medical Research in the BCG prophylaxis study in South India, and I conducted myself leprosy prevention trial, a big 5-arm study spanning over 15 years, covering a population of something like 500,000. And we had 4 different surveys conducted in that population close about Chennai in Tamil Nadu in India. I was also technical advisory group chairman for WHO on leprosy for 2 terms. And that was the period when we declared leprosy elimination in 2000. So that's how I got into different levels for leprosy work also, from actually conducting to taking further the whole thing. I was chair in epidemiology for Indian Council of Medical Research for roughly about 8 years or so. And then I retired. When I say I retired, I continue doing a lot of work with respect to immunizations, particularly National Technical Advisory Group on immunization, nutrition, epidemic investigations. One Health is a very special subject on which I continue to work even now. So that's my long introduction. It's not a very brief one I talked about.
Thank you so much, Dr. Gupte. Thank you so much. Dr. Gupte, those 9 lessons, they are very powerful lessons who teach us how we can transform the world in a better place for our future generations. So for you, Dr. Gupte, what does it mean to be a better ancestor?
Well, let me tell you first of all, these 9 lessons is a kind of philosophy. It's a structure which helps us to understand how we proceed, not only for epidemic investigations, not only for public health work, not only for collaborations, but also how to proceed in life. Now that's how Dr. Will Faggy, has taught us through all these 9 lessons. So that's how I look at it. And these 9 lessons, knowingly or unknowingly, I've been following those 9 lessons in different ways. While mentoring my students, while doing investigations myself, while working on several different areas and so on, including establishing National Institute of One Health in India, and taking further the leprosy program at global level. So these 9 lessons, even though we did not have those 9 lessons per se, The experience that I had in smallpox days under Don Francis and Bill Peggy at times when I used to meet him in Lucknow. So that's how the whole thing has taken further. And I know it's a very overarching kind of a structure which helps us everywhere. That's how I look at these 9 lessons. And these lessons definitely help us in taking the message of field epidemiology further. That's how I look at it.
Thank you, Dr. Gupte. Dr. Gupte, you were the one who was there in the ground working for the India government in the smallpox eradication program. Can you tell us how it was to work on the smallpox eradication program on that time?
Yeah, as I mentioned to
What
you,
was your role? Yes, what was your role and why you decided to be part of this project?
yeah. As I mentioned to you, I was working in a medical college in Pune under government of Maharashtra. And when I was working over there, I established my smallpox laboratory. I established laboratory for various epidemic investigations. So the field work and lab work was always hand in hand as far as I'm concerned. We talk of AP lab or we talk of AP lab, and that's how I started my whole career all along. When I started working in Maharashtra, a state in India, I was looking after several epidemics. One of those was in Patan, a hilly area, and I used to go there every month to see our medical interns. I was leading the medical internship program, mentoring them that time, helping them in learning several things as we do in field epidemiology. So I started doing those things. When I went to Patan, I was told that there is a case of chickenpox and an epidemic of chickenpox. Now, chickenpox is something that we ignore, so I did not much bother about it. Next month, when I went again, they said, yes, the chickenpox is still going on. These were the rainy days. I said, well, doesn't matter. I would like to go and see the place and see the patients. And then we come to some conclusion. They tried to persuade me not to go because it's hilly, it's rainy, it's all muddy, steep hills on which you cannot walk. The jeep can't go over there. I said, I still want to go. So I went over there with all kinds of hurdles facing, went up. It was a plateau on the hilltop. And there's a small hut separate from the village proper. Of exanthematous fever was kept. I looked at him. I collected some scabs. The clinical picture was very, very obvious. It was smallpox. I collected, I came down, told the medical officer that this is a case of smallpox. I went to the district health officer, woke him up in the midnight, told him what exactly it is, went to my laboratory in about an hour and a half, put up a gel diffusion test those days, and the test was positive. I reported to government of Maharashtra. They initiated the entire action immediately. The local level people were trying to hide everything in spite of knowing that this is smallpox. Now, with this background, when the smallpox eradication campaign came up in India, government of Maharashtra chose me that you should go and work over there in Uttar Pradesh. I was the youngest person, youngest epidemiologist, WHO epidemiologist to work over there. I must have been around 26 years old that time. The rest of them were all professors with a lot of experience to their credit. And I was the lone person who had just begun his career as a lecturer and worked with them. So that's how it all started. I was given a district called Muradabad. I never realized that Muradabad is a very difficult district. After my work on smallpox was over, I got my post-graduation also subsequently. And then I started looking for several different kinds of diseases, one of them being poliomyelitis. And in India, Muradabad district was one district where a lot of hurdles were there, a lot of difficulties in vaccinating people, immunizing children, following them over a period of time, getting the samples and working over there. Muradabad was not getting under control. And when I realized this, well, I worked in Muradabad and I did control smallpox in that particular district. I had two teams when I was working in Muradabad. And our work consisted of essentially surveillance and containment. I had two teams with me, two jeeps, about 10, 12 persons. And we used to go around, look for smallpox cases, talk to people, go to various markets, village markets, and find out if I can get some news about smallpox. Go to those places, investigate. I prepared lots of epidemic curves, lots of spot maps, and all those things were being presented at Lucknow, where we used to have a regional meeting. And Don Francis did take up all those documents and asked me to meet Dr. Bill Fagin. That was my first opportunity to see Bill Fagin and understand from him how the work needs to be done. I was very grateful. Eventually, I got the book of Bill Fagin. The House on Fire. You have a copy of this also, which is signed by Bill
Yes,
Fagin.
I have.
So this is a very precious possession with me. And that's how I started working in smallpox. And I did achieve something. I could not continue longer. Those people wanted me to stay there. But I was keen also to finish my post-graduation. So I came back to Pune. That's how it was in Uttar Pradesh, and that's how it was in. There are several epidemics that we saw in Muradabad. I can tell you one experience over there. I went to a PhD called CART. Talked to the medical officer. I said, well, I would like to go around and see the place, your area, talk to people and find out if there are smallpox cases. And I was told, CART is one area which is extremely difficult. The medical officer ignored me. He said, well, I have no time to go with you. I will give you a basic health worker who will take you around. The basic health worker, Mr. Ram Singh, he took me in my jeep. We came to a rivulet and he said, well, beyond this point, your jeep can't go. He made me sit on a horse to cross the rivulet. Hot summer day, the horse sat down in the water and somehow my others two came out. Then, of course, we walked for miles together, talking to people, meeting them, understanding what they think about smallpox, how much smallpox cases, epidemics are existing over there. When I came back, I literally had heat cramps and I collapsed. After 1 month, I went there over there again. And I told Ram Singh we are going again to those places. I want to check what exactly has happened. And Ram Singh said, yes, sir, we can go by jeep. I said, you told me that the jeep can't go over there. He said, yeah, I wanted to test you. I wanted to test your stamina. I wanted to see your commitment. Our doctors never go over there. But you are the one who have shown me that you really want to do something. And now we can go by jeep, we can see all the places, talk to people, find out the epidemics, and do all the work. That was one. The other thing was there's a place called Amroha. Amroha is a place where lots of Muslim population, essentially, and they had resistance to smallpox, the smallpox vaccination. And smallpox was raging over there for a couple of months. So it was a challenging one. I said, we'll have to do it. I went with entire team over there. And we tried to see from morning to evening, persuading the person, the village mukhia, who was not willing to talk to us, not willing to get vaccinations, not willing to get vaccination started over there. My colleague offered him, he said, I keep my head turban at your feet. My whole Self-respect is at your feet, at your command. That Mukhia, with tears in his eyes, said, please go ahead. Go ahead with your smallpox vaccination. I will not come in your way. And the whole village lined up for smallpox vaccination. And we conquered smallpox in Amroha as well. So that's the kind of thing that it went on. And lots of things we learned to obey.
Thank you so much, Dr. Gupte. Now that you talk about the vaccination, so in one of the lessons, we saw that there was a time that there was a shift on the strategy from vaccination to surveillance and containment. Can you talk about this change on the strategy and what was the main challenge that you faced?
I will tell you. But before you go further, Cynthia, I will tell you the tie which I'm wearing today. It is a very, very special tie that I'm wearing. It's a tie which celebrates smallpox eradication. This was made by CDC. I have bifurcated needles printed on that. And I've got also the smallpox virus decorating the tie. And I thought,
amazing.
I thought that for today's meeting with you and discussions that we are going to have, this tie is one thing which is a very memorable thing I should have along with me. You asked me about the ring vaccination. You asked me about the surveillance and containment activities. Now, there was a time, actually, R.A. Henderson, he was the chief for WHO leprosy program. His services were loaned by CDC to WHO for smallpox eradication. And smallpox eradication was being taken up in a very, very big way. In Nigeria, where Bill Faggy was working, they found that the vaccine is in short supply. And Nigeria was facing a big problem of smallpox. So Dr. Faggy thought, what we need to do now? There is not enough vaccine to go ahead and do 80% vaccination to achieve herd immunity. In fact, the herd immunity concept itself was wrong. Because if you are leaving 20% people out of vaccination, smallpox will find them. Smallpox will catch up with them, and smallpox will live. You have seen that happening with measles. You have seen that happening with several other diseases also. The same was happening also with smallpox. However, Bill Faggy thought that, well, under the given situation, we should do surveillance, identify cases, going all over Nigeria, identifying difficult areas, find out cases, do vaccination only for the immediate contacts and the contacts who are coming close to the patient of smallpox. He started doing that. The work went on and on like that. By the time smallpox vaccine in sufficient quantity arrived in Nigeria, it was realized that smallpox is no longer there and vaccine is no longer required in that particular sense. So that was the beginning. With this information available, with this kind of headway available, Bill Faggy and his colleagues and WHO in general started working in Africa. There was a 5-year program. They achieved smallpox eradication virtually in Africa in 3.5 years with much less money, saving time and saving precious lives. So that's how the whole work started. The thing like the bifurcated needle, which saves the vaccine, which makes life very easy for people who are working over there for smallpox vaccination, we were enjoying the work. And people had no hesitation. They used to come. A lot of persuasion was required at times, but yes, we were able to achieve a number of things. To this extent, after achieving work in Moradabad, I was interested with 2 more districts, Nainital and Rampur, where also I worked for some time. So that's how the story of smallpox in Uttar Pradesh, where I worked.
Thank you, Dr. Gupte. So those 9 lessons, they provide a framework for talking about your experience that we can pass to the future generations. Do you think that those 9 lessons can also be used to other global health problems that we are facing today?
Yes, certainly. Those 9 lessons are extremely useful. And I'll give you some examples, for instance. When you talk of cause and effect, we generally think of disease and a disease causing organism or disease causing agent, whatever it may be. I would like to go beyond this concept of cause and effect. The effect need not be necessarily only disease. The effect can be something different also, like hesitancy for vaccination, as we have been facing in Corona time also, or the stigma that we face against diseases like HIV, leprosy. We can take up that also and use these lessons to go ahead and work. So this is what with respect to cause and effect. And the cause and effect, when we start with a new disease, we may not know the cause at all, but we would still know how the disease comes, from where it possibly coming, and what we need to do about it. In the days of leprosy, in the earlier days, medieval days particularly, there was hardly any knowledge available. So the immediate response that time of public health was isolation and segregation and ostracism also. Now this was the earlier experience with plague, experience with smallpox, with even smallpox, leprosy as I mentioned to you. But then we came a long way. We have laboratories, we have genomics today, we've got artificial infusions, and the development of vaccines and new drugs. We can come very close to identifying the cause, developing interventions, all those things come true. So it's with the first lesson, which helps us to tell people, tell our students, tell our and do the mentoring work. Apart from that, this also helps us to take the lessons, take the messages to policymakers and several other things. This is the first lesson, cause and effect. The second is know, share, and act. This is something our basic work as far as field epidemiology is concerned. You'll agree with me. You have been doing that, I have been doing that. Our students, our scholars, if they do some work and if they find something, if they find water getting contaminated, well getting contaminated, we want to know what they have done beyond that point. If there is no action, there is no field epidemiology. And that's what it helps us also, the second lesson, that know, share, and act on the truth. The third lesson is coalitions are absolutely essential. And everyone knows that. When we work, we can't do our own work individually. In public health, it's impossible. We have to meet people, we have to talk to them, we have to get them together. We have to see that our management helps us. We have to see our logistics works and so on. Now, for all those things, we can't do it alone. We have to have a group. We have to have people from different spheres, not only one sector, but multi-sectoral kind of approach. And this is particularly true for conditions like One Health. You can't do it alone ever. When you talk of environment, when you talk of animal health, when you talk of human health, you can't do it with one single health department for human beings. You need forest, you need agriculture, you need animal health. And this is how we go ahead with respect to coalition developments. And Lisa, who is with us today in some way or the other, is one, along with Mark Rosenberg, has developed this particular topic of collaboration to a very, very great extent. It's a very enjoyable experience to go through that book. And I will advise all my students, they should look into it, they should learn it, and they should practice it. So that's the importance of coalitions. We say avoid certainty. No better example than HIV. With human immunodeficiency that we caught up in the 80s, we never knew anything like how it comes, why it comes. We knew the people who are affected. We knew the communities who are affected. And those communities we're essentially having stigma, self-stigma as well as population stigma. There was ostracism. And then gradually over a period of time, we learned, yes, it's the HIV virus, possibly coming from again animals, the simian virus, which perhaps converted to human immunodeficiency virus also. So this animal health to human health zoonosis is a concept we can never forget. So this is what we got from avoid certainty. You can't talk of one thing at a time. The same thing, no better example, corona. We know that coronavirus, we think it came from laboratory. Did it come from animals? Possibly yes. Now there is no clear evidence available to us on that. So we look at various possibilities. But what we need to look for is perhaps probabilities, and those probabilities will come from data. So we need to look into data, analyze that, and then consider the probability and go ahead with our implementation. So that much with respect to avoid certainty. You can't go ahead with one single hypothesis at a time. You need to examine several things. I'll tell you, you perhaps know Paul from London School of Hygiene and Tropical Medicine. Now, Paul is the one who takes Hanuman from India as his guide for epidemiology. Because Hanuman was one who went to Himalaya, picked up the whole mountain, because he could not identify which herb that he has to pick up. He took the mountain, came to Sri Lanka, and then it was possible to pick up what herb we need to do and so on. So we collect all kinds of things when it comes to epidemiology, form a hypothesis, examine that, and go ahead. So this is what we learn from avoiding certainty. Building evaluation and improvement is the next lesson. Now, if we don't do that, we're going to mislead ourselves. We're going to mislead our stakeholders who are working with us and lose the whole confidence. I'll give the example of leprosy here again. When Dapsone became available for leprosy treatment, there were absolutely hilarious kind of development took place. People were very happy. Then we had the Dapsone resistance coming up. Dapsone persistence were there. Now, when we had the resistance, we never knew what to do. Multi-drug therapy came up, and that multi-drug therapy was implemented immediately, even without a clinical trial. It was a cart before the horse. And the hope was, when we reach most of our leprosy patients and treat them, then we are removing the source of infection from the community, and leprosy will die down. It never happened. Leprosy persisted. It's impossible to identify each and every case. It's impossible to identify those cases fairly early. So even before the symptoms would have arise, they would have done the damage. So doing this kind of work and imagining that, well, you are going to achieve elimination or eradication in a short period of time was a wrong dream that we had. We never bothered about it. Evaluation, where we are going to lead to. So evaluation is absolutely essential, and that's what we have been doing all along. The next is respect the culture. Culture matters. You know it so well. When you're working in Mozambique, you can't forget what people want, how they live, how they depend on the forest, how they depend on the animals which they catch in forest and work. If you don't do that, if you don't look at them, if you don't say that, well, you're going deep inside, what care you need to take. If you don't respect those feelings, we are going to nowhere. We learned in Ebola that during Ebola, when the case comes up, they will take all care, as we did in smallpox also. We never allowed anybody else to come close to the patient. We kept the patient segregated. But when the patient died, the patient used to come out in the corpse was brought in the open, and everybody came around. They were performing puja or whatever religious ceremony. We need to stop it. But you can't stop it just like that. You have to educate the people. We need to know what they want to do, how they want to do it, why they want to do it. And then, unless we know all those things, and then be with them and tell them the importance of the work that we are doing and why it has to be done that way, they are not going to follow us. So culture is something which we can never forget. The next lesson was seek strong leadership and management. We talked about it some time back. Now, without management, strong management, nothing can happen. In fact, when you need a manager, you need not be a doctor always. A manager can be somebody else who is experienced in management. But we will learn our trade also to the extent required and help us in that. They will manage our logistics, they will manage our man force, the force that we need, public health force that we need. They will manage also our travel. They will manage how to get the funds, from where to get the funds, and all those things. Without management is extremely difficult. It's impossible, particularly at global level. When you are dealing with a disease like smallpox, you need to have funding not only from one place, but from different places, different NGOs, different governments, your own governments, as well as people who are working with different areas. So we need to have these kinds of evaluations, we need to have these kinds of managers as well. And lastly, if you forget equity, we saw it in COVID-19. When we had different varieties of COVID emerging, in Africa in particular, and the way it was spreading to UK and USA, there was no vaccine in Africa at that time. We from India talked about vaccine friendship, but the developed world wanted to keep all the vaccines to themselves. They did not want to share it in the beginning. They realized later. If you forget this equity, which is essential, you cannot conquer any disease. Because if the disease is lurking somewhere, it's going to hit you also. So that's how these 9 lessons are important. And we go ahead with those 9 lessons everywhere. Thank you.
Thank you. And do you think that provided by those 9 lessons is a framework that artists can organize their own experience, or even countries, they can use this framework?
Yeah, I would agree with you.
To document lessons.
Yeah, I entirely agree with you, but I would perhaps say, if we look at again COVID-19, it is not only the long COVID, but the post-COVID also. And we are now facing, because of COVID-19, in 2020 and 21, we could hardly do any other work in health. We continued to do somehow to manage Corona. And that was the soul and whole thing. We ignored vaccinations. We ignored our other programs. So we're getting a lot of cases of tuberculosis, a lot of cases of leprosy with deformities. And today I learned from Mumbai, Bombay, what a number of people understand. There are 20 deaths because of measles in Bombay. About 20,000 people have not been, 20,000 children have not been immunized in that city. A large chunk of children all over the world have not received measles vaccine. You can imagine how the measles elimination program, which was supposed to be achieved, when you are going to achieve. We have some funds available still for polio. I hope it persists. But without the funds, we know that polio vaccine is creating itself a problem. The oral polio vaccine is creating vaccine associated with poliomyelitis. We saw that happening in USA. We saw that could be happening in UK and different other places. We need to be aware of that. And this is how these 9 lessons are important. This is the basic framework, the structure, overarching structure. But we have to use them and develop our own new generations of health philosophers, as I would like to call them. It's not only the field epidemiologists that we are looking for, but we want to tell them that, well, a time will come that you need to look beyond your own generation, beyond the present century. And if you want to do that, we need to go beyond these 9 generations. It's an evolution. And in that evolution, I look at these 9 lessons as the first step.
Thank you so much, Dr. Gupte. It was so amazing to have these conversations with you. I believe that we all have a lot of learn from you, from your experience on smallpox eradication. Thank you.
Thank you. Thank you, Cynthia. It was an opportunity for me to go through my old experiences and learn the whole thing all over again. Nice talking to you, nice meeting you. And as you said, hopefully we should meet sometime soon in person. Thanks a lot.
For sure. Thank you.